Our last talk, but not least, is by Dr. Daya about post-keratoplasty ametropia, principle of management.
Great, thank you. Well, post-LASIK ametropia. Well, the majority of times of cases after a graft, certainly a penetrating graft, is you'll find patients have myopic astigmatism. They seem to get myopic as the graft heals and the cornea steepens up. Now, the biggest issue is astigmatism, and this can be from a variety of things that occur at the time of the operation or afterwards. A poorly centered graft, unequal fibrosis, a step from a poorly sutured wound. So suturing is very, very important. And also peripheral ectasia, which I showed you earlier on today. The traditional approach has been to use spectacles, then contact lenses, soft, and then gas permeable, and scleral lenses are going to be very popular. And then there's refractive surgery. So refractive surgery can be either lens-based, you can add a phakic lens in if the patient can be refracted to a good level, or lens replacement, as you can see in this patient here who's had a toric lens and they're in their 70s with developed a cataract. They had a good refractive correction and a regular cornea, so they could afford that. Then there's cornea-based procedures, which I'll go through in a moment. When approaching these patients, you need to find out what the cause of the astigmatism is, and that determines the approach. If it's a poorly centered graft, well, that can be a big issue. If there's unequal fibrosis, well, you could address that. You can, if you have a step in the wound, that could be a disaster if you choose the wrong procedure. And it really depends on the corneal shape, the cause of the shape disorder, and the magnitude of the refractive error. So the important thing is the examination to evaluate the graft-host interface, correlate shape change with topography, and then ask the question, what's the cause? Is it because it's fibrosis, or is it because it's wound slippage? Or could it be peripheral ectasia? And each one of those needs to be, it could be a combination, and you have to figure out which is the most riskiest situation. I already showed you this patient who was a general practitioner. I'm not going to go through that again. So wedge resection is one way of correcting areas of peripheral ectasia. Let me go through these quickly. I hadn't realized these were in the same session. This is just some of the outcomes, and we published this a while ago. So wound fibrosis, what can you do if there's wound fibrosis? The graft-host interface is fine, there's no slippage, but you can actually do an astigmatic keratotomy with or without compression sutures. There are also nomograms for this. It really depends on the level of fibrosis. And the graft-host interface is like a new limbus, so you really want to be doing the astigmatic keratotomy at the junction or within the graft. Doing it outside the graft, which is practiced at one of the greatest hospitals in the UK, is a nonsense. It doesn't do anything at all. So it can be performed with slit lamp, and this is me being quite aggressive here, dealing with patients with a super blade at the slit lamp. You'll notice I have the blade coming towards me. So if they move forward, I've got the blunt end as not the sharp end going towards the cornea. And this works very well. It can be titrated from visit to visit. And it can be very, very effective in treating fibrosis as a cause of astigmatism. I'm doing this on the other side here using the same sort of technique. A femtosecond laser can be used to do intrastromal AKs, and these are very good. If you use high energy, you can actually use the bubbles to open up the incisions within the graft-host interface. Again, it's quite variable in terms of how this works, but if it doesn't work, you can go do exactly what I just did with even a Sinskey hook and open up the incision. I usually wait for about 6 weeks because I find I sometimes get nothing on day one, and then 6 weeks later I get 10 diopters change in astigmatism, sometimes going in the wrong direction. So this is a femtosecond laser. Again, this is great because you can you've got online OCT, you can decide how deep you want to go. And this is an intrastromal ablation that we're doing right here. And in this particular case, the patient did very, very well with I say, 10 diopters of correction at 6 weeks. And day one, he was only 1 diopter of correction. But waiting is worthwhile. Don't try and be too aggressive. You're treating the patient, not yourself. So this is the actual treatment taking place, and it takes more time setting it all up than it does to actually press the pedal and do the correction. And you can see that online OCT showing the intrastromal bubbles. What about laser refractive surgery? Post-PK astigmatism. Photorefractive keratectomy has been done. I don't advocate it. This is there are some problems. You can get persistent epithelial defects, which you've heard all about this morning. You have increased inflammation, so you can get antigen presentation, endothelial cell dropout from the inflammation. There's a limited level of correction, and then you can get haze and scarring. Now, mitomycin C has been used, but we've seen patients with late haze like this after mitomycin C. This is a patient sent to me from St. Elsewhere's with troubles. With LASIK, it can be done, but there's an increased rate of complications. There's less inflammation. You can enhance the patients earlier, and you can be combined with other modalities as well. These are some of the big risks: wound dehiscence, perforation of thin, and a buttonhole. This is one of my worst cases of a microkeratome LASIK on a PK, and this is the hansatome. So you have to have blind faith, as they say, and you actually see there's actually a perforation there inferiorly from wound slippage and a cut. Well, we always have a suture kit available in our room when we do refractive surgery, just in case. So LASIK after PK, you got to evaluate those patients properly, make sure there's no poor graft to host apposition. Avoid doing elderly patients. Large pupils can be a problem because you've got a graft and you've got large pupils. You're changing the corneal surface in terms of shape. Avoid patients with systemic rheumatological disease and ocular surface disease. And those high-risk penetrating keratoplasties are not the patients to be doing LASIK. And we did a large series a while ago on using a microkeratome. I'm not going to go through all the data. I'll bore you with it. Suffice it to say, it worked very well. The problem is, at 2 years, we found patients were doing worse. Those patients that had keratoconus, when we created a flap that extended into the periphery, they started developing ectasia in the periphery. So LASIK with a microkeratome is not a good idea in patients who have an underlying diagnosis of keratoconus. This is to illustrate more data showing pretty good results. But 96% had 6/12 vision or better at a couple of years. But then there were ones that I say, I've seen these patients now 20 years later, and they've got ectasia in the periphery. So be careful. These are the complications. We had one free flap, 3 partial flaps, 3 buttonholes. As you can see, the buttonhole there, and 1 perforation as well. I showed you earlier on. You can get epithelial ingrowth, rejection episodes. Patients with herpes simplex can get recurrences. They need to be put on acyclovir. And 4 of our patients wind up with regrafts. So that's a pretty serious issue after doing refractive surgery on patients who have had transplants. We've devised ways of doing bitoric ablations to treat very high levels of correction, and these work very, very well. I won't get into it in this is a kind of advanced level. I wrote my own software to do this, and now it's been incorporated into the Bausch & Lomb software, and very effective in treating very high levels of astigmatism. Femtosecond lasers can now be used as well, and these are great because you can actually make the cut within the graft itself. So you're not involving the peripheral cornea, and there are issues with vertical bubble breakthrough. You've got to be quite bold when you do this sort of surgery. That didn't worry me in this particular case. I still lifted the flap and treated the patient. And they actually do very, very well. This is on a DLK patient as opposed to a penetrating graft. So this option of a femtosecond laser to create the flaps is good. I have to say I don't do that as much these days. I use phakic lenses in most of my patients because it's an additive and reversible procedure. But there are patients who have hyperopic astigmatism where this treatment works very, very well. So there's a very thin flap here because you have got to handle it very, very gingerly. A very thin flap too. And you go ahead and treat. So there's controversies as to whether you cut, wait, and then re-refract and treat. That's debatable. We can talk about that in the discussion if we have time. So laser surgery is effective. The more chances of flap complications. I think a femtosecond laser is a better option. And be careful in patients with keratoconus. You could wind up causing more trouble in the long term. And remember, hallmark of a successful procedure is a stable outcome in the long term. Thank you for your attention.
Thank you again. A very interesting talk.